Well, thrilled to see such a nice audience here today. I know we're up against some stiff competition, and I hope that this conversation that we have today will be very enlightening. I'm thrilled to be here with Ken Davis, who is a real thought leader in medicine. And what I want to do is take us through a number of topics, looking forward over the next 25 years, but also encourage you to think about your questions. So at about 2 o'clock, we're going to open up the mic here, and you can just line up, and we'll go through your questions, your thoughts about what's coming up in the next 25 years. So the first area that I want to touch on was one that Eric Lander raised yesterday during the conversation session, and this is the area of genomics. And I don't think that there's any area in science that has been put forward with such promise. One of the points that he made is that we tend to overestimate the short-term returns on this sort of technology, but we underestimate what it might do for us in the long term. It's been more than a decade since the genome was sequenced. Mount Sinai is investing in genomics in a big way. And so it's clear that the feeling is that there is going to be payoff there. Why is Sinai taking this on as such a big project?
Well, you know, when we think about genomics, we think about what's really possible 10, 15, 20 years down the road. And what's really provided a sea change in how we're going to use genomic data is supercomputers and big data analysis. And that's what kind of wasn't there at the beginning when we first had that one patient who Eric talked about, one patient from Buffalo, who, you know, for $3 billion we sequenced his genome. Well, right now, Eric said yesterday we can sequence a genome for $3,000. We probably do it for somewhat less, actually. And in a few years, it'll be $300, and probably in 10 years, it may be a routine laboratory test at $30. So there's an unbelievable amount of data. The question is, how do you use that data? And how can you really make sense of that data? We believe at Mount Sinai, and I think a lot of other people around the world believe, that between the algorithms that the mathematicians bring to us and the power of the supercomputer, combined with all your genomic data, we can look at your genome in a way that is analogous to what microscopes did to understand bacteria and what telescopes did to understand astronomy. It will open up an entirely new field for us to understand. And let me give you some examples of what the Mount Sinai group, collaborating with lots of other people from all over the world, has already found in a number of diseases. We took 1,000 brains, 500 with Alzheimer's disease, 500 were normal controls, and sequenced the genome in those brains and asked, so what genes differentiate those late onset, real life, real kind of Alzheimer's, not the rare mutations that happen when you're 55 and 60, but the common kind of Alzheimer's disease, age 75, 80, 85. What happens when we compare those brains with normal control brains? And when you look at the kind of mathematics that is possible today with the supercomputer, which is a problem not unlike what Facebook asks and who's a group that works together and what ad we're going to use, what we found out is a group of genes that have to do with inflammation are all telling us what Alzheimer's disease is about. And those inflammatory genes may have a lot to do with whether amyloid gets cleared from your brain or not. And there are some genes that are more powerful in that group than others. So subsequently, another paper comes out that finds that one of those important genes that we found, we as 50 people from all over the world, that one of those other genes also is a risk factor for Alzheimer's disease, and that there are new targets for Alzheimer's disease therapeutics that we previously weren't thinking about. That comes from using the supercomputer with thousands of samples and analyzing the problem in a new way. So when Eric talks about it's going to be a revolution, I think he's right. Things will be very different down the road, but they're not going to be apparent within the next couple of years to all of us in this audience.
Now, when it comes to genomics and the individual decision about getting their genome sequenced, I noticed that Mount Sinai has a very innovative program now for some of your medical students coming in. where they can get their genome sequenced.
Yeah.
Why are you moving in that direction?
Oh, well, we think it's a great educational tool. And it gets the medical students thinking about prevention, conceptualizing disease in a different way, and understanding the possibilities of the future of science. So, you know, we do it for the medical students, again, as an educational tool, not as a health tool. And they do learn a lot. They come out and they say, my God, I got a risk factor for that? I didn't know I had a risk factor for that. I got to change my life, you know? And it does get you to think that way. Now, obviously, if I was to sequence everybody's genome in this room, you know, some of you would come up with a risk factor for macular degeneration, and some of you would come up with the risk factors for Alzheimer's disease, and some would come up with some of the known cardiovascular things, and some of you would want to know it, and some of you wouldn't want to know it, and some of you would change your life about it, and some of you wouldn't. But you're probably all sophisticated enough to be leading healthy lives anyway. So I'm not asking you guys to all sequence your genome right now, because I don't think it's that useful on an everyday basis, but I think in a short while it will be.
How long do you think it will be before genome sequencing outpaces a good family history in determining risk?
I think for some diseases and for some reactions to drugs it does right now. You want to know, if you're going to be on a drug like Coumadin, what your genetic profile is for metabolizing that drug. And the same is true of things like simvastatin and some of the antidepressants and a number of other drugs. So depending on the circumstance, you might want that information. If I may just take one more circumstance that some people in this room might be super sensitized to if you've gone through this. If you had to go through with yourselves or with your children in vitro fertilization, you know that one of the issues with in vitro fertilization is you've got a bunch of fertilized embryos. And which ones are you going to implant? Well, what we can do now, and we're doing now with our OBs, is doing a sequence of the genomes of those embryos. And we're giving a health index score for what each of those embryos are. So you can make a decision. Do you want to have a child who's going to carry the BRCA1 gene? Do you want to have a child who's going to have a high risk for Alzheimer's because they got the ApoE4 gene? Now that's not covered by an insurance company, but a lot of families who are looking at this and have already the torture of in vitro fertilization are thinking, you know, I can really make a good decision now about what embryo I want to implant. So for those people, it's a very valuable test.
You know, one concern that's been raised by critics of genomic sequencing is that public policy hasn't caught up with technology. Right now, there are protections around genetic discrimination, but there are no protections in terms of life insurance, disability insurance, long-term care insurance. For someone thinking about getting their genome sequenced, how should that play in, and what would you like to see over the next 25 years to make it easier for people to get this information without fear?
Well, there are two sides to this equation. Eric Lander talked yesterday about the necessity that large amounts of genetic information be depersonalized so that we can use it to learn more about disease. Because for some diseases, you may need 20, 30,000 genomes to really understand it. So we need to be able to protect the databases, depersonalize the databases so that we can use the data. But when you get the data, you have to be secure in knowing that the insurance company isn't going to get it and somebody else isn't going to misuse it. And we need those protections in the law right now. Or when you obtain your information, you've got to make sure it's not going to be disseminated and it is all yours.
The Supreme Court recently ruled that human genes cannot be patented. This was a landmark ruling. Do you think that this will put barriers in terms of companies moving forward with doing research, or open the door to further collaboration?
Well, let's understand what the circumstance was and why some people were so upset about it. So Myriad Genetics figures out that the BRCA1 gene is a risk factor because they're looking at all the science. They look, the BRCA1 gene is a risk factor for ovarian and breast cancer. And they develop a test that is proprietary because they get a patent around it. And now they charge a fortune for that test, and they say it's a return on their investment, but they're making a lot of money on this test. And it's quite different from other tests that you might have in medicine where we do your LDLs, you know, and nobody's making a fortune on your LDLs. The lab is kind of making a little bit of a margin, but it's not anything like Myriad Genetics. So the question becomes, what happens if you could patent genes, gene after gene, that might be a risk factor for various diseases, and these companies go into business, and it becomes very expensive for you to get the test? Well, clearly, that's not in the best interest of public health. But what Eric was concerned about yesterday is he's worried that he might not even be able to use those genes in a larger supercomputer kind of model to figure out what are risk factors for other diseases. So it will hamper research. So this is a good decision for science moving forward, and it's a good decision for public health. What we don't want is for it ultimately to go a few steps further downstream that would inhibit innovation by companies that are then going to use that as a target to develop drugs around. We're going to need those.
Earlier this morning, I heard you on a panel that was looking at scientific advances and translating those into new drug development. And so I want to think forward over the next 25 years. The trend that we've been seeing over the past couple decades has involved mergers of pharmaceutical companies, fewer and fewer companies doing independent R&D, and a movement towards companies looking for the next blockbuster drug. One of the areas that comes to mind to me is the area of antibiotic resistance, and the fact that for some infections we're moving towards the end of the antibiotic era. There's no economic incentive for these kind of drugs to be developed by private industry. Moving forward over the next 25 years, do you see any changes to the model for drug development?
This is a critical question. We really have to align what's public policy, best public policy, with a business model that works for big pharma. Because right now, if you look at what Peggy Hamburg and the group that we spoke at 1020 talked about in the ecosystem of innovation, if you think about that, what we have is a lot of misalignments along the way, and those misalignments are best seen as the incongruity between what is the best business model for big pharma and what the public health needs for important drugs. For instance, some of you have probably heard about this virus that's coming out of the Middle East that's got a lethality that is suggested to be as high as 50%. Undoubtedly, as more people populate the world and viruses march on, we're likely to find some horrible virus someplace that will mutate away and be terribly contagious and could have a substantial epidemic. What we would like is to have an armamentarium of therapeutics that knows how to deal with that. The question is the incentives for the pharmaceutical company to develop such a drug. Well, right now, there aren't even incentives to develop new antibiotics for treatment-resistant bacteria, let alone to think about what viruses might mutate and what kind of vaccines or therapeutics will develop for those. On the other side of that equation is, well, what does big pharma do well? Well, and where are the profit margins for them? So I would like to point out, and I always do, the Nexium example. Everybody knows the purple pill? So, but few of you probably know that the purple pill is essentially Prilosec. It's the old Prilosec, which is omeprazole when you go into Walgreens or CVS, and you can buy a little packet for 1/10 the price, even less than you get for Nexium. The only difference is Prilosec is the DL form of the drug, and Nexium is just the L form, which is the active form. And Forest Pharmaceutical has done that with Celexa and Lexapro. You make a lot of money that way. There's not a lot of development cost. The drug's probably going to work. You can do the clinical trials. There'll be a lot of patent life left on the drug. And boom, you know, good return on investment. Stockholders are happy. Everybody looks good. On the other hand, a drug for Alzheimer's disease, now we know, could take 10+ years in people who are pre-symptomatic before we can know that that drug is efficacious. It could even be 20 years. you look at that and you look at patent law and you say, my God, what kind of drug company is going to invest in that? So when we've got diseases that are in years and years and decades in developing your body, we need preventions to alter the course of those diseases. There may not be any business incentive at the end of the drug's development and discovery period for a company to take it on. So we've got to change the incentives. We've got to make the incentives align with what the people need. And what we need are drugs for bad chronic diseases. And when we get those drugs, we've got to reimburse them adequately, we've got to give them long exclusivity, and we can't be tied down by arcane patent laws that don't really deal with what's the reality of biomedical research today.
I'm going to shift topics. I'm surveying a lot of topics to give you some fodder for your questions coming up. Medical education. As we move forward in the next 25 years, healthcare providers are going to need a different set of skills than they currently do. And I know Sinai has been innovating around how you're recruiting and developing your curriculum. What do you see medical education looking like?
We've done two important things around this. The first starts with team building, because we think that doctors have to be a part of a team. They have to know how to work collegially in a team to work with people at different license levels, sometimes be the leader of the team, sometimes not be the leader of the team, but definitely understand that it takes a group of people to keep you well or out of the hospital or from having a readmission. Now, that means that we want our students from the beginning to work in a group. So the first day of medical school, when our medical students come, on the very first day, they're all sitting there in class, what they get is an assignment. And the assignment is, we want you to take $80 or whatever number we give them the money, and we want you to figure out how to go to these 3 places in the city, and then where you're going to eat lunch. Go and then report back to us how you did it. And there's a prize for the team that gets there first and functions the best. So they all sit down at the end of the day and they tell us what happened. And what happened is they had to develop a strategy, because some people in the group knew where the particular site that they were going to go in Manhattan was, others didn't. So people in the group had different levels of knowledge. Some people knew where they would go for lunch. They had to decide where they would go and how they would pay for it. So they begin to understand that right away, day one, you are a team, you're going to work as a team. And when they go to anatomy, they work as a team. And when they get graded, they come around, our preceptors come around to the anatomy lab, to the anatomy table, and they quiz the group, and the group gets a grade, not the individual gets a grade. So we're beginning to get them from day one to understand that medicine's about team building, and you got to be a team player. Now, that isn't all. What we've also learned is that to be a great doctor today, you might need different skills than we thought about 100 years ago, when we had a revolution in medicine and the Flexner revolution decided that we had to have a certain curriculum, and it was a pretty standard scientific curriculum. And now, if you are any doctors in the audience, you have your kids who wanted to go to medical school, you know they had a prescribed curriculum that everybody has to take as a prerequisite to get into medical school. Well, we think a lot of that stuff is perhaps not that valuable anymore. So we want to open it up to people from broader range of disciplines. So we like to have a mathematician come to us who maybe is going to take organic chemistry with us in the summer. And we think that you can really have a terrific person who may come from a statistical background, because we're going to need that too. And we think that the MCAT exam isn't the be-all and end-all, so we don't want those kids to even take the MCATs. We're accepting students now at the end. They apply at the end of their freshman year. So during their sophomore year, they apply. We ask them to come to us during the summer and take some of the science courses they might not otherwise take. And we want them to take either an intensive science background, perhaps genetics, perhaps biochemistry, and not have to worry about the courses that they otherwise would have had as prerequisites, or to sometimes take humanities and then not have to worry about, oh my God, what am I going to get in physics? They'll never get into medical school this way. So we've changed the preconditions, we've changed the prerequisites, we've changed the way we teach them, and we think we're going to get better doctors that way.
I want to ask a little more about that. You know, when I I look at students today and look at our kids, it's a very connected world. It's connected through electronics. When I look at my own interaction with my patients, I'm looking at a computer screen a lot more now than I'm looking at a patient. But when you talk to people about what they want in a doctor, it's a connection. Yeah. It's that ability to communicate. I heard in a previous interview you'd done that many of the lectures students are taking remotely because they can take the information. How are our healthcare providers learning that human touch, that humanity that patients and people really want?
Yes, these are great questions. Well, I give this lecture every year on schizophrenia, 2-hour lecture. I've been a schizophrenia researcher for a long time. And I figure, I'm the CEO and I give a pretty good lecture. There should be a lot of kids in the class. So more than half the seats are empty now. And they're catching me on the web. I'm a digital star, but I'm not in the classroom, which is kind of disquieting if you've been doing this, for 35 years. So you lose the human touch. And to emphasize Richard's point, the electronic medical record in some settings has resulted in in physicians spending 80% of their time on the screen and only 20% of their time with their patients. And in those instances, when we find that happens in some specialties, we assign a scribe to be at the keyboard instead of having the physician at the keyboard so that we can have more patient interaction. But you're right. I mean, patients want to see their doctors and they want the human touch. And we all know that, Marcus Welby is a role model for those of us old enough to remember Marcus Welby. So what do we do about that? We have a course in an Introduction to Medicine for the first 2 years of our medical school in which we team super clinicians with 4 students. And those clinicians are role model people. They are your unbelievably warm, kind, sensitive, great clinicians, humanists. They are often from my generation. We believe, and that may be because Dennis Charney, the dean of the school, and we're both psychiatrists, we believe in role modeling, that we get a lot of value out of role modeling, out of putting the right doctors with these students who we carefully screen for people that we think are going to be a little more sensitive from the work that they've done previously, a little more extroverted. So we put these, what we think are good students with great role models, and they're with those role models for a couple hours a week for nearly 2 years. And it begins to rub off.
I want to shift to the area of healthcare reform. And we've had the Affordable Care Act passed. Yep. But going forward, when this act was passed, most people said this is not the end of healthcare reform. It was put forward as a way to provide insurance to more, but it doesn't do much in terms of dealing with healthcare costs.
Right.
What do you see as still necessary over the next 25 years to see real healthcare reform?
Right. Well, we could use that as a springboard to talk about what the ACA is and what the ACA isn't. So the ACA was designed, Obamacare was designed as to enhance access, to give more people access to care. My daughter worked for Senator Whitehouse. She was a health legislative aide. She was on the committee, the health committee, that was drafting this bill. And she's a better version of me, so she's Ken 2.0. And she was pretty assertive in this, although she wouldn't talk to me about it. Afterwards, I got to learn a lot about this bill, but I was in Washington a lot to talk about this bill and to work on it with them. And it's clear it was all about access. And the only thing that started to deal with reform is when the people from the Midwest would look at the Dartmouth Atlas, which is a compendium of comparative pricing, and they'd say, gee, in Rochester, Minnesota, it costs a lot less to have an MI than it does in New York City or LA or Miami, and we should start paying for value. We shouldn't just start paying for these, outcomes. So there was a lot of discussion about value-based purchasing, and that was the impetus for reform in the bill. So what reform we have, and there's some good reforms in the bill, but not nearly enough, are around setting up things called accountable care organizations. The accountable care organization is a shared savings model in Medicare. We at Mount Sinai are an accountable care organization. We've entered some 25,000 patients into our accountable care organization. And what it does is it said, let's look at your last 3 years of Medicare spending. And if in the next 12 months, on those 25,000 patients, you spend less than you did in the average of those last 3 years, we'll split the savings with you. Now, this is revolutionary, because what this does for the first time is it says, if you can keep your patients well and keep them out of the hospital so that they don't spend money in health care, we're going to let you share in those savings. So patients got to be well, Medicare wins, the payer wins, and the provider of care wins, because everybody's aligned the same way to keep people well. That's really great, but some of you might be thinking, sounds like that HMO that they tried to sell me some time ago, when all they wanted to do was deny care. Because a fee-for-service care is every time we do something, you pay. This is the exact opposite. Every time we don't do something, we make money. So that would suggest that we should provide as little care as possible. The good thing about the ACOs, which are different from the HMOs, and this is also a part of the ACA and its subsequent regulation, is that there are quality metrics that we have to meet. And if we don't meet those quality metrics first, we don't get any savings. And there are some rigid and strict and important quality metrics around our ACO. So we have a system now that is in some way a first step toward reform. If we can move beyond always trying to repeal the ACA and start to think about how to improve it, we can begin to think about other ways to reform healthcare. Because as has been said, it's the law of the land now, and there are a lot of deficiencies in it from Mount Sinai. We're going to lose a lot of money on something called dish payments, which is a subtlety that this room doesn't need to know about, but it has to do with very low income people or people who are uninsured in the poverty level. But we're going to lose a lot of money on the ACA. It's time that we start to fix it instead of try to repeal it. And I think when we try to fix it, we can deal with more issues of how do we improve quality, how do we get more prevention, how do we pay for the things that we want, and how do we start to bend the cost curve on Medicare.
I mean, one of the concerns you've raised is what healthcare reform will mean for academic medical centers. What are your concerns there, and what safeguards would you want to see in place moving forward?
Well, Mount Sinai is not unlike probably 20 other great academic medical centers around the country, where a top 15 U.S. News and World Report hospital, or we're a top 15 kind of medical school. We're third in the country in dollars per NIH investigator. But we're 62% Medicare and Medicaid. We serve an underprivileged population in East and Central Harlem. We take care of everybody. And a lot of everybody's can't afford care. When a patient comes from, a Medicaid comes to our emergency room, we have 100,000 visits in our Mount Sinai Hospital emergency room, and he has Medicaid, we'll get paid $100. It'll cost us $400 for that visit. So we cross-subsidize a lot of things in order that at the end of the year, we can have a small positive margin that we use for our medical school so that we can do science. The question is, as the country and the states can't afford Medicare and Medicaid, and the margins keep shrinking, and it's usually provider cuts. I mean, we've taken enormous provider cuts. What's going to be the margin left for innovation, for science, for the medical school, for academics? Remember, and this is a hard thing to conceptualize, but keep this in mind. Drug discovery today is largely coming out of academic medical centers. Drug development comes out of big pharma. If the drug discovery engine is stifled because the leading academic medical centers in urban areas that take care of poor people have negative margins, which a lot of them are starting to think about, we are hurting one of the great American resources, one of the great engines of innovation. And that's what we've got to protect. And at this juncture, that's been a hard thing to enter into the dialogue.
Over the past few years, there's been studies coming out showing the value of surgery for treatment of obesity, for treatment of diabetes. the healthcare system is largely structured around a treatment model. Moving forward, do you foresee changes to the health system that would provide compensation for true prevention?
Absolutely. If we're paid to manage a population, like we are now with the ACO, if insurance companies say, these 50,000 people who get care from Mount Sinai, we're going to give you X amount of dollars for, then our incentive is to keep everybody well, keep everybody out of the hospital. We just got to make sure that when we do that, we don't have what I said is the perverse system of having physicians and hospitals deny care because they're making money by not providing care. So we have to have very strong quality metrics to make sure that the quality is maintained at the same time that we're doing less.
One of the things that Obamacare did was, as you say, pull more people under the umbrella,
right,
with access to care. When health reform went through in Massachusetts, they saw a major shortage in primary
Yes.
care providers.
Yes.
As a pediatrician, I'm acutely aware that physician salaries for pediatricians, family doctors, are the lowest of the low. But this healthcare reform did nothing in terms of restructuring payments to physicians, or in other ways providing incentives for people to go into primary care. Moving forward for the next 25 years, do you see that kind of reform taking place, or do you see other providers coming in to provide preventive care, or a different model?
Well, there are already marketplace events that are causing primary care doctors to make more money now. As value-based purchasing and as accountable care organizations and as insurance companies have increasingly wanted to manage care, they manage care with the primary care physician as the hub, and in pediatrics as the general pediatrician as the hub. There aren't enough to go around. So we've seen our need to increase the salaries of those people to get the best primary care doctors in our system. So I think that the marketplace to some degree is going to begin to emphasize the value of the primary care pediatrician, the primary care internist more and more. They will not reach the salaries of some of the obscene levels that the interventional cardiologists get and some of the other people. And that's still got to be addressed. I mean, downstream, we still have to address the inequalities. For instance, in our hospital, our starting pediatrician is going to earn 40 times less than our interventional cardiologist.
Pretty incredible. That's why I'm at ABC News instead of General Pediatrics. Get ready with your questions. I'm going to ask another question, but then you can begin to line up over here and to ask Dr. Davis your own. This is a little bit of the crystal ball time. I want you to project forward in 25 years, looking at medical breakthroughs. First in an area where you are a world-leading expert, and that's Alzheimer's disease. Okay. In 25 years, do you see this as preventable and treatable?
I think it will be true. Well, let me say it this way. When I began the first drugs that were currently used, so the drugs, Aricept, Reminil, Rivastigmine, all those drugs came from my giving that class of drugs. The first time I gave it was 1978. If somebody told me that 35 years later, I'd be worried that I could get Alzheimer's disease, I'd say that's impossible. But those are the drugs from 35 years ago are still on the market, and that's all we got. Nonetheless, I think the next 25 years will be better. I really would be very surprised if we don't have a way to delay the onset of Alzheimer's disease by some 10 years with what we're learning now about what Alzheimer's is. So that instead of having its peak age of onset, say 80, it might be 90, and you'll have much fewer people affected by it. Whether we can totally obliterate it, I'm less certain of. So I see good things for Alzheimer's. I see great things for cancer. I think it's going to be incredible. Just like Eric Lander said, what we're learning in cancer almost every day. I can tell you 3 amazing things that just happened at Mount Sinai alone in the last year that are breathtaking in what they're going to mean for cancer treatment. So I'm very optimistic about where we're going to be with cancer. Brain diseases, when I talk about brain diseases, I mean addictions, schizophrenia, depression, OCD, anxiety, and add to that dementia. Those 6 diseases account for more disability. There 6 of the 10 leading causes of disability are those in the world. How well will we do on brain disease? I'm a little less optimistic about. Brain's very, very complicated. I expect we'll get better generations of some of these antidepressants and antipsychotics because we'll be able to grow neurons in the laboratory that came from you and people with disease, and we can use that as a much better test model to develop better systems. But I don't think we're going to have the kind of breakthroughs that we'd like to see in brain disease.
I want to open it to questions. When you come to the mic, if you can please keep your questions short, identify who you are, and if you're with a group, what group you're with.
But the last kind of breakthrough, which I think is going to make a lot of people in this room happy, I wouldn't be surprised if we can inject cartilage into your knee from stem cell research that some of my Sinai colleagues have told me about.
A lot of smiling faces.
Instead of having total knee replacements, we may be able to have stem cell biology used to create your own cartilage and grow that back.
Yeah.
My name is Mitch Besser. I'm with an organization called Mothers to Mothers, which is in Africa, but I want to ask a domestic question. I trained as a doctor 35 years ago in what would have been the dark ages of medical education, and I'm pleased to hear some of the advances that have been made. I'm aware that much of what I was trained to do was diagnostics and therapeutics and surgery. I'm aware increasingly that the issues that we face in medicine are around issues of excess. People eat too much, drink too much, smoke too much, don't exercise enough. And yet, the question is, in medical education, in the next 25 years, what measures do you think we're going to undertake to try and drive behavior change? And as doctors have less and less time with patients, and perhaps not the skills or the interest, how are we going to change people's behaviors to generate better health?
You know, this is a great, great question. Some of the really bad drivers of healthcare costs are under our control, like what we eat and whether we exercise. So it's clear that it would be an unusual medical student who doesn't know that today. The question, of course, is cajoling by your doctor doesn't seem to be adequate. So the real issue is whether the country and public policy can really take this on. We haven't been afraid to take it on with tobacco and alcohol, but are we going to take it on with sugar is the real question. And what are we going to do about the processed foods and the way we eat? And what are we going to do even for the way we organize our day? I mean, are we going to make sure that every kid in every classroom, beginning from kindergarten on, has an hour of serious exercise a day? And we build that in. And, you know, we have adequate facilities so that kids understand from day one, you know, you've got to exercise every day. It's like eating. It's like sleeping. So I think that we as physicians can begin to make the case, but we've got to have leaders, public leaders, who understand this. You know, and instead of talking about death panels, start to talk about the real behavioral abnormalities that we have that are driving healthcare costs.
Bob Engler, I'm a professor of medicine and also in biotechnology. If you were to sequence my genome and not know anything about my family history, so ignore Bayes' theorem, et cetera, what I really want to know, if you tell me about a risk for a disease, is what the positive and negative predictive values are.
Right.
And you might want to explain that a bit. But for example, for Alzheimer's,
sure.
What kind of positive and negative predictive values are you seeing?
So we don't know that yet. We don't know that yet, which is why you asked the question. You're a smart guy, and you knew you'd get me.
Exactly my point.
I know. So, but we will.
If you can first explain what positive and negative predictive.
In other words, if you've got a risk gene for Alzheimer's disease, does that mean you're inevitably going to get it? No. Nothing seems to be inevitable in biology.
And conversely.
If you don't have the risk gene, you still might get it.
Right.
So that's what we want to be able to communicate along with that. However, when you communicate that, let's say I say you got an ApoE4 gene and that triples your risk for Alzheimer's disease over the normal population, and 30% of people over age 80 are going to be demented, so your chance is a lot higher. But if I also tell you that if you exercise 30 minutes a day vigorously, it's going to be significantly decreased, that's all you need to know. You should exercise.
But shouldn't everyone exercise anyway?
Yeah, probably. But some people don't.
Right.
You know, we had in the first session a wonderful session by a healthcare economist, not healthcare, an economist, a behavioral economist, who was talking about how we don't do things that we ought to do. And we all know we ought to exercise. And if you ask people, are you going to exercise 2 days from now or 3 days from now or a week from now, they all got it planned. But if you say you want to exercise now, tomorrow, right, by 4 o'clock, well, I'll see. My day's kind of crowded. So we've got to figure out a way to build that in.
Please.
Hi, my name's Carol Fant. I'm founder of One Brave Cowgirl. It's a blog for dementia caregivers that starts next month. For those of us who have rampant Alzheimer's and other forms of dementia in the family, is there any good medical reason from a research standpoint or other standpoint, for instance, for me to go get genome sequencing or anything else when there's no cure?
This is a great question that I'm asked. I was just asked a week ago by one of the rare patients I still see. And I advise no. He wanted an amyvid scan where you can see amyloid. So if we scanned this room, given the average age of this room, 30% of you would have positive scans for amyloid in your brains right now. That doesn't mean that you all live long enough you're going to get Alzheimer's, although you've got an increased risk if you got those positive scans. So he wanted to know. He wanted a scan. And I said, I don't think you should have a scan, and I don't think you need to know your ApoE status, because there's not a whole lot we're going to do about it right now. When we have a therapeutic, do it, or if you want to enter a clinical trial, do it. But now the best thing I can tell you is, exercise a lot, drink red wine, and a few other things that I would tell him.
I'm a PhD clinical psychologist that has a company that provides large-scale mental health services to corporations and hospitals around the country. With that said, you mentioned ACOs, and clearly I think that's going to be very impacting, play around with the cost curve in a positive way. Speak a little bit of bringing it down to a more community level. Organizations like Johns Hopkins and a variety of others are playing around with medical homes, where they're putting psychologists, physicians, what have you, PAs, into hitting lifestyle-based engagement, which clearly is where the war is at.
Yep. So I love this question because it is really where healthcare is going. Medical homes are the notion that a team of people are responsible for your care. And those teams are often much lower licenses than MDs. And in fact, on our medical home models and our managed care teams, the most critical people are often college graduates with no advanced degrees who we sit with for a couple of months and teach them how to be case managers. And their job, and this is where the electronic medical record and places like Hopkins and Sinai can use supercomputers come into play, is we have a huge database of hundreds of thousands of patients on our electronic medical record now. And we can ask, well, who are those people who wind up most in the emergency room and get readmitted the most? So we've got that figured out. We've identified those people. And then we figured out, well, what are the factors that lead to that? So we've identified high-risk patients, and we assign them case managers and a managed care team. And every day, our electronic medical record, with the help of our data warehouse and our computers, spit out for those case managers all the things that they've got to worry about for those patients. And they call them up and they ask them things like, what'd you eat? What's your weight? Did you take your medication? We see it's running out. Did you renew it? You've got an appointment tomorrow. Are you going to come? If you can't, we'll get some transportation to make sure you do. And that all comes from, data warehouse, electronic medical records, supercomputer, and smart mathematical algorithms. On that team's got to be psychologists, everybody, so that we can change behavior. You can't change behavior unless you're in their face every day.
You're essentially chaperoning that patient.
Absolutely.
To wellness.
Absolutely.
Thank you.
Thank you.
Anton van Akmal, you mentioned two things that make the Human Genome Project so operationally useful: supercomputers and big data. Isn't there a third, which is robots?
Robots.
If now, for example, this high throughput screening at NIH they can do in 1 day what it used to cost 12 years, that is an enormous efficiency.
Absolutely right.
Now, so that was the first question, but out of that is the question, if you look, and I'm an economist, not a medical doctor, if you look at this cost curve that we're also worried about in terms of healthcare,
Yeah.
the cost curve in healthcare is really what is driving the budget, long-term budget deficit.
Yeah.
Could you make an argument that as a result of the targeted bombing that we can do instead of the carpet bombing now, with our knowledge that we are gaining and all of these things together, the combination of all of these things, that you could actually bend that cost curve down significantly and much more than we think, that we could have a positive surprise here?
I think it's...
By targeted, what do you mean?
Well, basically, if you use chemotherapy, only 1% reaches the bad cells, and if you can up that percentage to 60% as a result of your knowledge of genetics, could
right.
you do? Yeah, that's what I mean.
What we're talking about here is the use of genetics to identify subgroups of patients who will have very robust responses because their genetics, the mutations in their genome and then the cancers have been identified so we can target their treatment. So if we target treatment, won't we be able to bend the cost curve is your question. Right. And my answer is maybe a little bit. But here's what we forget. Everybody in this room's got an expiration date. And at the end of that time, we've got the last year of life. And it's very expensive. 30% of our Medicare costs are in 5% of people at the last year of life. And I can assure you right now, there are a bunch of people in Mount Sinai Hospital who don't have living wills, who don't have advance directives, who are all tied up to machines that they probably didn't want to be on if they had the ability to have given us an advance directive, and they're costing the Medicare system a lot of money. So no matter, if we live to 120, we're still going to have that 120th year is going to be expensive. And we've got to start to think about how to manage that year in a way that is humane. And to me, that's the much better use of palliative care, which is very effective in patient satisfaction and in prolonging life and in decreasing costs. We've got to be able to do that and address this issue that's been so hard at this juncture.
Next question.
Ken, you and I live longer. We have both exercised.
Tom's one of my bosses.
Anyway,
he's a trustee of
I'm
Mount
one of
Sinai.
Ken's trustees. To what extent, Ken, do you see more of an integration with the next generation of medical students of traditional medicine and alternative medicine?
There's a lot to learn from alternative medicine. It is clear that a lot of people benefit quite a bit from yoga and meditation. The science that has attempted to show efficacy for herbal preparations generally fails. Those trials never show the efficacy that was touted by the label on the pill or what you might have read in some blog or internet site. But there's still a lot to learn from alternative medicine. And clearly I think it will spend a bigger role.
I mean, one of the things that is said about practitioners of alternative medicine compared to practitioners of Western medicine comes down to that relationship again, and that a provider who is listening and working with the patient from where they are. One of the concerns that I brought up before is that issue of so much is focused on the technology and technology as the answer. And as one of the questions raised, for many of these, we know what those causes are. And finding a way to engage with the patient around those issues may take some different skills.
Absolutely right.
Yeah.
Hi, my name is Mark Rinaldi. I lead Naya Health, which is a global health organization that works in Nepal. I also have a domestic question, however, submitted by my girlfriend, who actually cannot be here because she's a medical student, even though she really wanted to ask you this question. So, truthfully, I just texted her and said I could ask you. So she wants to know what you see your role, what's your role specifically in bridging that disparity between primary care and specialty care? Because where she goes, she's a tough student. She said actually the insurers drove that. Wanting to reward primary care for good outcomes.
So we're establishing things that we call polyclinics, which are kind of mega malls of care with 70 to 100 docs and one-stop shopping for all care, and it's 50% primary care, 50% specialty care, all within the same building. For patients, it's really great because they see their primary care doc, and when they need specialty care, they're referred within the same facility to a colleague who shares the same electronic medical record. So as we build out these clinics, we're building them on the base of 50% primary care. But we know that what we do really well at Mount Sinai is tertiary and quaternary care. So we want to make that as seamless as we can, so we don't have a division here.
Hi, Gary Lazar. I'm a medical oncologist and a biotech executive. My question is about one of your comments, which I found very curious, and that has to do with primary care physicians and the ability of primary care physicians to do better under the Affordable Care Act. We've had this experiment in California for the last 25 years with capitation. It's been a dismal failure. No primary care physicians have made more money, and the only thing that's happened is it's driven primary care physicians to not take insurance.
Right.
So why do you think New York is different than California?
I can only tell you our experience that has been over the last 2 years, and that's been a robust market for hiring primary care docs, for employing them, for raising their salaries, because I don't know what these guys are thinking in California, but I can tell you what my friends at Partners tell me and what I know about the economics of a primary care doctor. For every primary care doctor we hire at Mount Sinai, they will generate enough admissions to our system that we'll have a $1.5 million margin on those patients. The consequence is I can pay those people more, and I will. And in our polyclinic model, what I talked about, we will pay our primary care physicians at the 75th percentile or better because we know the downstream income from them are worth it. So maybe in California they're too decentralized, or the hospitals don't think like this, or maybe they're already, the best system is Kaiser and they've already got it figured out, where they pay the primary care physicians a decent salary. So I don't know what's happening there, but I can tell you what's happening in our system, and I value the primary care doctors. And I just gave you the economic analysis why.
So my friends in primary care are going to
come
move
to
New
me
York.
if they're good. They got to be high quality.
Thanks so much for all of the influence that Mount Sinai is having on the rest of the country. Just a side note, at the American Family Physicians meeting recently, there was a primary care physician who said to me, I used to be a primary care physician and now I'm a typist. So just a point to, I'm glad you're taking care of them, but I'm not sure there are enough people who want to go into it.
Oh, you're right. I mean, look, when the disparities in income are as great as they are, and when we are now paying primary care physicians, maybe even we get up to 200, 250, and we're still paying 4 times that for interventional radiologists, and the neurosurgeons making $1.5 million, and the cardiothoracic surgeons making $2-3 million, and these kids come with enormous debt from college and from medical school. They're going to make economic decisions.
Yeah, my question was actually, so my name is Kelly Close and I work at the Diatribe Foundation, so mostly on chronic disease, specifically diabetes and obesity. And I wondered your opinion in 25 years, this is to your point on what's driving behavioral abnormalities. Will our government still be subsidizing corn? What is your view on this? The view on subsidizing fruit and vegetables for low-income people. Is anything going to change on this front to help give people's incentives to eat healthily?
If this were only about doctors, of course it would change. But as long as the Iowa primary is first and we pledge allegiance to corn, you're going to get what you're going to get in high fructose corn syrup.
Short question.
Hi, my name is Rothstein. I'm spearheading a rural health and wellness campus in eastern Ohio. So we have a rural, moderate, low-income population. Say a word, if you would, about the full integration of mental health and primary care, and the benefits and challenges of doing that over this next 25 years.
I don't know if most people in this room can appreciate what a very important question this is, but this is really, really critical, and it's something that we have really obsessed over. It's a tortuous problem, and here's why. So you get very ill people with chronic, persistent mental illness, and they're often dual diagnosis, so that they have bad psychiatric disease and they're addicted. they get medical problems. In fact, some of the drugs they take make them very much overweight, and they get type 2 diabetes, and they really need help. Well, the internist doesn't even want to deal with them. I mean, they don't know how to address the psychiatric problems and their likelihood of compliance, so they don't want to see them. The psychiatrist has never been trained adequately in internal medicine and the kind of chronic diseases that are going to present. So these people fall through the cracks. And what we're trying to do is integrate the mental health providers with the primary care people. And sometimes the lead person on that team is a psychiatrist who feels competent in treating the common medical conditions like hypertension and lipid problems and type 2 diabetes. And sometimes it's training the internist to feel comfortable with treating severe depressions and OCD and psychoses. But it's a real gap that you've put your finger on, and we've got to do a better job at it in medicine.
Ken, one last question before we have to close. The course of medicine and healthcare over the 20th century was filled with advances, and each generation had the wonderful experience of living longer than the generation before. Current predictions are that this generation of children will not live longer than their parents. What needs to happen over the next 25 years so that that's not inevitable?
So we're ending on a real downer.
No, the hope.
But that's the truth.
Yeah.
That's the truth. I mean, our children's generation will not live as long as ours. That's the first time in history that that's happened. And the reason is about obesity. And it's about type 2 diabetes. And what's the hope that the next 25 years we'll get in touch with that?
Yeah.
I think that answer to that lies as much with politicians as with the likelihood that medicine will come up with a breakthrough compound that will delay the onset of type 2 diabetes.
As the advocates for health, I mean, what role do doctors have to play in that policy debate?
You know, I think we've got to be on the forefront of saying that we've got to start dealing with sugar and regulating it in our diet. You know, and a lot of people aren't going to like to hear that.
Ken, I want to thank you very much for a great hour. Thank you all for your questions.
Really cool.
Thanks. That was